One. Hello and welcome again to Confronting the Complex. This is Dr. Jamie Kunkle with Janell Payne. Hi, Janelle. How's it going?
Hi, good morning. I'm good. Happy Friday.
Wonderful. Yeah, thank you. We're on Friday today. We were on
Excited for it.
Sunday last
Woo!
time. Yay, Friday.
This is a
It's
better day.
springtime. It is way better.
I mean, like Sundays, like I'm too relaxed.
Yeah, I'm a little too chill too. I gotta have a little bit of that cortisol left, a little bit of
I know.
adrenaline left to get a little fire.
Yeah. I
You
have to
know,
be
so
still a little wound up.
I'm all down for it. I'm not quite parasympathetic
Agreed.
yet. So let's go.
Let's go.
So today we're going to do probably a shorter segment, although you never know with us. We might end up talking for an hour for some reason. We're going to probably do a shorter segment on GLP-1 agonists. So the great semaglutide, tirzepatide, and all their lovely little
And for those
brand
that don't
names.
know, what are semaglutide and tirzepatide for the broader audience that maybe isn't in our world?
Yeah, let's define it first, because what the heck are these things and why are we even talking about them? I'll let you lead on that front.
Well, like
Go.
Ozempic, Mounjaro,
Yes.
Bound, right? Like Wengovi,
Wegovy.
Wegovy,
Wegovy.
Wegovy.
Weg-
And so all these drugs is what we're talking about. Like,
Those
like,
guys.
yeah, you can hear it on all the ads. I love to sing the little jingle for Ozempic. And
Oh,
my
there's a jingle. I didn't know that.
Ozempic. You haven't
Oh,
seen
that's
that?
right. No, I
Oh, it's
have
so great.
actually.
And I get it stuck in my head and my family gets really annoyed, as you can imagine. Anyway, okay. I promise to never sing again on air. That will not be good
So,
for views.
so to be clear, these guys have been researched and FDA approved for weight loss, and that's kind of what their primary use is mostly. And it's specifically for folks with diabetes type 2, usually obesity, hemoglobin A1C over whatever. I can't remember if it's like 6 or something like that. There's all these different guidelines depending on the insurance, and that's really what they rushed it through to cover was a lot of the weight loss game. But these things actually have a lot of other functions, and we're going to kind of discuss some of those today too. But just so everybody knows, that's why everybody talks about them is that like they're sort of a quick path to weight loss, and that's what the pharmaceutical industry has sort of capitalized on these, and that's why they're super expensive. And we'll talk about accessibility and how what they did to compounding, like they always
Oh
do.
yeah, prices are coming down though. I mean, let's just touch on that
Yes.
right now because for the last couple of months we've been receiving this onslaught of emails. You can't access it beyond this date. You can't access it beyond this date because it's no longer on the shortage list, right? The FDA
Right.
shortage list. Because it was so popular, compounding pharmacies could make it because it was on an FDA shortage list. Now it's considered neither one of them, tirzepatide nor semaglutide. That's Ozempic and Mounjaro and Ozempic.
Yeah.
Like,
But as usual, I have to say, the commercial products are not for everybody in terms of like sensitive patients and stuff
yeah.
like that. There's not really a way to entirely control dosing when you're dealing with an auto injector and basically a
Exactly.
recipe uh dosage structure, so we'll talk
Yes.
about that a little bit too. So it's kind of a fun game. So I'll sort of play a little bit of the lovely opposition to these things too here today. I'm not like against any of these drugs, by the way, and I've used quite a lot of peptide therapies in general, and so I understand sort of where these things live in the process. And I have to say, I will talk a lot about some of these lovely repurpose uses that we're learning and exploring, especially in the field of mast cell activation, these very sensitive patients too. So,
Yeah.
anyway, why don't you kick it off there, Janelle? Tell me what your experience is with these things and where you find value in them in your practice.
Yeah. And I'll try to take the stance of a little bit more for them. And I kind of genuinely am more for them, right? But at the
So it's
same time,
true.
there's a caution. So I appreciate that friendly opposition to it, right? Like for the
Oh yeah,
sake of
totally.
conversation. Um, I started experiencing it when, like, well, I'll just tell you anecdotally, personally, like I worked too many hours and I would sit in front of a computer and my lifestyle was terrible, right? And I tried a lot of dietary things because that's the only thing I could do. I couldn't get out and exercise the volume that I wanted to, yada yada, typical story, right? Of somebody who spends 60 hours in front of a computer screen. Gained weight since, COVID weight. And when the GLPs came out, I was like, I mean, I'm to the point now where I need to try this. I either need to buy a new wardrobe or I need to try this, right? I'm bursting out the seams. So I tried it myself and I was like, Okay, this is kind of amazing. And I mean, my appetite went down, that emotional eating, the
Mm-hmm.
hangriness went away. Um, I started sleeping better, feeling better, and since then, I go off of it and I've gained some of the weight back, which is fine. Like I lost 20 pounds. Great, like it
Wow.
was just, but I fit back into my clothes. That's what I wanted. I just wanted to fit back into my clothes. Now, mind you, by the FDA standards or the insurance standards, my BMI wasn't technically high enough to be approved for these medications, right? So
Right.
going through one of my colleagues who prescribed semaglutide for me, like that was really helpful in like just maintaining, like before I become diabetic, before I have cardiovascular disease, right? Like before
Sure.
some of these other things set in, we were able to kind of reverse course, if you will. And then it was motivating to go out and want to exercise and right because I fit into things and I wasn't as embarrassed to go to the gym and
Hmm.
life.
Yeah.
I mean, I hate to say it, but life. And I just felt better.
Yeah.
I was sharper. And then subsequently, my joint pains mostly alleviated. Now, I
Wow.
don't feel pain on a regular basis, but I do like I have a few joints that, like act up. We all have those joints that act up.
Hmm.
And I can tell you, like, or I could tell you back when I was taking it regularly that as I was ready for redosing, that those joint pains would kind of flare again. And
Hmm.
would redose and the joint pains would kind of mellow out. And so it just kind of got me thinking, like, what is really happening here? Is it because I'm not eating the foods that were inflammatory to begin with?
Hmm.
Potentially, but I've done that before with minimal help. I mean, I won't say minimal, like I've done that before, right? And I would find it wasn't overly satisfying. Um, anyway, what else do you want to know?
Well, yeah, no, I mean, I think that's cool because I mean, these meds are directly anti-inflammatory and they're sort of indirectly or secondarily
Yeah.
anti-inflammatory, but they can directly modulate TNF alpha and I believe IL-10, which is the anti-inflammatory cytokine, among
And
others.
IL-6 and CRP.
IL-6, yeah, all of the
I mean, you
above.
name
I
it.
mean, it's
Yes.
cool. And then if you get the whole metabolic syndrome that comes with like insulin resistance and what leads to diabetes and what contributes to even stuff like hypercholesterolemia, high cholesterol, and blood sugar dysregulation, and all these other things, Alzheimer's, even like dementia and other things like this, which some people have termed the type 3 diabetes. So like
Yes.
neurologic health, all this stuff, it hits all these different pathways in different ways, and so yeah, it sounds like a miracle drug a little bit, but really
Right.
honestly, if you're talking about prevention and mitigation of those things, it might be a good thing to have on board. And maybe then you never neglect like the foundations of health. We talked about that many times
Right.
before on these podcasts. You certainly want to, as you mentioned, diet, healthy diet, exercise, movement, mental health. But I've really seen this unstuck people in situations and circumstances in their life, and there's really no judgment there. Why people choose to go that path or not in
Right.
different times. I've seen it really improve the quality of life of several of my patients with similar types of stories, and they just feel so much more confident and comfortable in their body and
For
just
sure.
all of this. It's beautiful. So yeah, there's a
Well,
lot
and
of
my husband, so I
stuff.
tried it on us first, right? Before I put it out there to my patient population. Because as you
Right.
know, we see a very sensitive, complex chronic illness population that tends to gain weight and resistant to weight loss techniques,
Yeah.
standard weight loss techniques. That whole reduce calories and exercise more doesn't work for our patient population. And you probably see that as well,
Oh,
right?
yes.
Yeah.
Yeah, and
I
of
mean,
course those patients still get judged. They still get,
oh, yeah,
labeled by conventional folks. I had a patient just go all the way to a different state to get a consult with somebody, and they're just like, you just got a case of, fat, basically. It's
right,
crazy. And
right.
even though
And
they're not seeing in between the lines, these people are
right.
metabolically challenged because of their chronic inflammation.
Yeah,
So,
that's it,
yeah.
perfectly stated. Metabolically challenged with because of their chronic inflammation. My husband, who struggled with high blood pressure like his whole life that I've known him, like on semaglutide, while he didn't have this like the easy dramatic weight loss that I had, his blood pressure normalized. And it was like,
Yeah.
well, winner, right?
Yeah.
Like, and with a significant family history of unregulated blood pressure, right? So for him to be able to do that after being on every blood pressure medication seemingly known to man,
Yeah.
huge, right? That's huge.
We'll do a talk on blood pressure sometime because people do
Yeah.
forget that a lot of times blood pressure elevations are in some form of, a manifestation of inflammation in the body. It
Absolutely.
can be autonomic dysregulation. It can be so many things, but we forget that like vascular inflammation or inflammation in the vascular space could also be a contributing force to it. Because I've seen time and time again, people need blood pressure meds, and that's why the conventional model of just palating these things is just crazy. They're not looking at the source or the cause of those problems. You
Yes.
address the cause of those problems, and things get better. Certainly, exercise can help too. A healthy life, a healthy diet could help too, but finding those deeper elements of the inflammation can go a very long way with blood pressure. So yeah, we'll do a talk on blood pressure sometimes. I think it's
Yeah.
an important topic. That's really cool. Thank you for sharing.
Yeah, it was
Yeah,
great. So then I started giving it to my patients who, again, kind of nervous, right? Because if any patient subset is going to have side effects, it's going to be our patient population.
true.
And so I started out really microdosing, and this is where the compounding comes in because you cannot microdose with the auto-injector pens. You just
Nope.
can't do it. And I mean, when I say microdose, and I mean a fraction, if 2 milligrams of semaglutide is the standard auto-injector dose, I was giving 0.25 milligrams, right?
Right.
Like a fraction of the dose because it's the only way to really titrate up that dosage, mitigate some of those side effects, and have patients be successful on it versus having a wallop of a dose right out of the gate and having to try to challenge their body to like tolerate it. Anyway,
Yeah,
for a whole host
people
of
are worried
reasons.
about the initial side effects whenever you're
Yeah.
injecting these things for the first time. What do you usually see as the typical side effects with a if somebody's given too high of a dose, especially,
Yeah, a
in our
lot of
patient
nausea,
nausea?
vomiting.
Yeah.
I had one patient, she had syncope, which is passing out. So she had some real dysregulation with it. And we
Yeah.
started small and we started with semaglutide, and then we switched her to tirzepatide and dosed even smaller, right? And she tolerated and is actually thriving on it right now. But I have several patients that I've had to make that switch with to tirzepatide because it's in general tolerated a little better. It doesn't have
Yeah.
quite the side effects that Ozempic has or semaglutide.
Yeah, it's different enough, and it does hit some other receptors aside from the GLP too
Yeah.
as well. And for our sensitive patients, and we've even found anecdotally in some of our mast cell patients labeled mast cell activation, sensitivity reactions, histamine, other things like this, that they do better with the tirzepatide for some reason. Like
Yes.
there's reasons we don't fully understand. And by the way, even on the mast cell and other inflammatory cells, they actually have these receptors. They have GLP-1 receptors even. So you may actually be getting like a direct modulation effect on some of the inflammatory parts of the system. So it's pretty cool.
Yeah. Yeah, and
So
which is kind of remarkable. And this is another case to advocate that, like these tirzepatide versus Ozempic, like, or excuse me, semaglutide. I use semaglutide more often because of its cost effectiveness, right?
yeah,
Like,
yeah,
a bottle, I think it's roughly, for a 1 ml bottle lasts most patients, I mean, you're supposed to use it 28 days. But it's about $250 for a bottle,
mhm,
upwards of
yeah,
300, depending on, who your pharmacy is. Like all pharmacies
right.
are priced just a little bit differently. Um, Anyway, long story short, is tirzepatide's higher in price, and so it can be cost prohibitive for some people. It's
Yeah, that
it's
makes total
not
sense.
quite twice the price, but it's easily another $150 more a month. So
Yeah. Yeah, that makes sense. Yeah, so usually you could start with the semaglutide if it makes sense,
yeah,
and then maybe you could, use
just
that as a
tolerate it.
secondary choice, unless the patient's like really sensitive. Maybe you could start higher if finances aren't a problem or something like that.
Yes. And I
Um,
frankly have used it in patients that don't need to lose weight. We keep it at such a dose that it's just a low dose to try to get some inflammatory modulation, right?
yeah,
In
yeah,
patients with
totally.
autoimmune, it actually works beautifully in patients with autoimmune that I've seen. Shocking.
So in the cases of injecting peptides in this manner, and I know that there actually are some compounded formulations that even go through the mouth or the mucosal tissue even, which is kind of cool.
Yeah.
So apparently there may in the future even be some commercial options for non-injectable routes. But what's the difference in these peptides kinetically speaking? I mean, I think I like to think of it as, we have our short-acting sort of peptide arrangements, and that's a lot of the really safe, kind of easy, to use, maybe BP 157 type things in the
Yeah.
peptide world. And then you have these longer acting, sort of more what I call like maybe more pharmacologic in terms of really creating a sustained functional change within the system. And that's like where I would put, the GLPs some of its other cohorts, peptides are kind of a pretty large spectrum, like insulin being a peptide, heparin being a peptide,
Right.
so
We have a lot
they're
of natural peptides.
we have a
Sure.
lot, and peptides, just for everybody out there that doesn't know, I mean, they're signals in the body. They're amino acid sequences. They're kind of protein-like in nature, and they can influence different tissues in the body. So a lot of times in the complex illness world, we'll use different peptide arrangements to try to modulate um certain physiology, certain functions within the system, within different organ systems, or within the immune system, even in cases of thymosin and stuff like that. So
Yeah.
yeah. So
And they
anyway,
are
that's
long acting. Their half-life is about 7 days. So if you have an
yeah.
adverse reaction, you could have a prolonged adverse reaction, right? So
It's
which
the
is why
low
I like
slow.
to microdose.
Yeah.
Microdose. It's
I
key.
remember once instead of doing once a week with somebody too, I like sort of split their dosage before too, where I do it like a little bit and then like a little bit a couple days later and a little bit.
Yeah.
So if they
I
do that
have
long
done that
acting,
as
you still
well.
get
If it's
the
really
timers
low.
up.
I was
Yeah.
like, if we're not making progress, we can dose twice a week, but we have to be dosing really small
Yeah,
twice.
totally.
So yeah,
So
for
there's a
sure.
lot of negative press on these GLPs also.
Yeah.
People would talk about it's going to basically like anesthetize or like paralyze my stomach or my gut, and like there is a theoretical risk of stopping the gut, like bowel obstruction or something. I've never seen this
Yes.
before, but it is a theoretical
I
risk.
have seen it.
Have you?
Have
Yeah.
seen it.
Yeah, so
Right
let's
out
talk
of the
about
gate.
some of these
Right.
concerns that
Yeah.
people are throwing out there. Okay, so yeah, so what happens if it has a long half-life and you give this drug and then it stops the gut up? What do you do?
Well, I give a whole slew of and well, I don't want to like necessarily dispense medical advice, but I get
By the way, we don't give medical advice here.
we
I
do
have that
not
in
give
my
medical advice.
disclaimer. We're just
But
information here.
yes, I give some natural substances or some medications, frankly, that promote gut motility, right? So
Ah,
I got to get the gut moving. I ask patients to drink water. I need you to walk. And I've even had patients give themselves an enema, right? Trying to stimulate that
mhm.
osmotic potential and get that gut moving, whatever we could do. Here's the problem that I have found, and I learned it early on, thank goodness, is that when patients are nauseous, they will go to Zofran, which is ondansetron, for those of you
Mhm.
who don't know what Zofran is. But when you have a surgery or you're giving a pain med post-surgery, you're often given a handful of Zofrans to deal with the nausea, with the pain meds, right? Like, so I feel like everybody has a little bit of Zofran on hand. And I have learned this the hard way. Like
Yeah,
it wasn't an isolated patient. This is like many patients. They feel nauseous and they're like, you know what works for nausea? Zofran. Oh no, my friend. Zofran is on that list of medications, top 10 medications that cause paralytic ileus, which means your bowels freeze. Purge,
yeah,
done. No more bowel movements. And so you take something like semaglutide, which is known to slow down that peristalsis movement activity. You add in some Zofran, and now you have a real problem. And so, and patients who take pain medications, a lot of our patients are on pain medications.
right.
With chronic illness, there's chronic pain. And we also know that pain medications can also paralyze those bowels. It can cause slow bowel movements. So I'm really cautious in the patients that are using a lot of these medications. And I basically say no Zofran.
Yeah.
You know, the
No,
good
you got
news
to just
is,
be clear to them. Yeah, you
yeah,
do.
no Zofran. It's on my list. It's actually just on my handout. Like, do not take this.
I see you have a
Ginger,
handout. That's a good thing.
I do have a handout. Ginger, though, ginger is like one of those natural substances that promotes gut motility, reduces nausea, is anti-inflammatory in and of itself. So I use a lot of ginger. I use a lot of magnesium, things that are just known to be
Yeah. I mean,
ginger.
there's a lot of good stuff there, and sometime maybe we'll talk about, more gut-related things. But prokinetics, as a general term, are great, and there's a lot of natural things: ginger, bitters, if they tolerate citrus, apple cider vinegar. Even I mean, there's like cinnamon. There's all these like
Yes.
digestive stimulants you can use. That a lot of them even help with the nausea effects in people. And then if you need like osmotics, like things that pull water in the bowels, you got the magnesiums and you got the minerals, and that's the hydration piece and all that kind of thing. And then if you need to move beyond that, you can hit it with like prokinetic drugs. And of course, my favorite is also the one that's not as easily accessible, like motegrity or precalopride, as a selective serotonin agonist for the gut, which tends to have a better side effect profile if you have to use but very rarely. do I see the need to sort of preload with big drugs in these cases. It's usually, the dosage might be too high, or you have to kind of play around a little bit with it. But as long as you have that up front, that information up front, they can be advised to have a proper action plan on how to address it, and then they can also, we usually have a very open communication with our patients, and we can mitigate a lot of that risk. So that's always the biggest concern I hear out in the media world. The other one, of course, is just philosophical, like, oh, you're given an easy fix to weight loss when there's a lot more of a complicated issue here. And we did talk a little bit about our chronic inflammation patients don't have an easy fix to weight loss sometimes.
They don't
And
have
it is
it.
clearly a risk factor for them developing these other secondary issues, what the conventional world defines as chronic illness, which is the heart disease and diabetes and different things like that. And even cancer, if you really want to extrapolate it as a metabolic disorder, all cancer is a metabolic disorder. So, you know, so,
Yeah, no, I
so,
agree.
but the philosophical piece to this, when people are like, "Oh, that's just too easy," why are you as a naturopath using this whenever you should really just be really doing better as a inflammation and lifestyle practitioner? I don't know. What
Right.
do you say to
It's
that?
because we've tried all those things, right? Like
Right,
I have, how many times have you had a patient come in and say, I'm doing all the things. I'm eating 1,200 calories a day, which I would argue is not enough, right? Like, but these are people that are literally like it, and I would argue that they need to eat more calories, which is counterintuitive, right? And they're focusing on low carbohydrate, that paleo diet. They tried autoimmune inflammatory diets. They try just meats and veggies, and then you have patients that are like, I'm just going to go all carnivore diet, right? Because it's the only way they can lose weight. And I would argue that these also aren't healthful, solutions long term, right? Like if you're narrowing what you put in your body, you are narrowing your or biodiversity, right? Your
right.
gut microbiome,
Microbiome,
right?
right.
You have to you have to have a wide variety of foods to feed a wide variety of microbiome. And we know that that's supposed to be the healthiest, right? Now, some patients are locked into that. They have to eat carnivore. Some patients are locked in, they have to eat a paleo autoimmune, right? So I'm not going to get into diet here. However, I've had patients try things and give them a really honest go for months at a time. I've had them exercise, we optimize their hormones. We do a lot of things and they still have this stubborn resistance. And then you start seeing their blood pressures going up. They're starting to have conditions like congestive heart failure. They're starting to build some plaque in their arteries. And frankly, we have to blunt that. We have to mitigate that.
Hmm.
And these GLP agonists, like semaglutide and tirzepatide, I'm using a lot of big words for people that aren't as accustomed to hearing this, but these drugs can help mitigate those risks. They actually reduce the risk of Alzheimer's, the studies are finding. They reduce the
Yeah,
risk of congestive heart failure. Like I was really nervous because I'm starting to use this on a lot of older patients, right, with a lot of
right,
comorbid conditions. So when I first got into prescribing these, I thought, I got to know all the people that I can't give this to, right? Like, who are
right.
my people that I can't give this to? Like the people with on a lot of cardiac medications or the people on a lot of, like I'm just, who can I get not give this to? Turns out very few. Like almost all markers for cardiovascular health are improved on these medications. I was astounded. Like when I really started digging into it.
Yeah.
So
Yeah, no, I mean
yeah,
the data don't lie. And
the data don't lie.
yeah, really, I've seen some pretty amazing shifts, even just in the lab work too, just the inflammatory
Sure.
markers, the metabolic markers,
The
everything. And
lipids,
yeah, yeah, lipids. I mean, it's crazy. And I know that I haven't gone here either, but I know people are talking about researching using this in like childhood obesity and different things like that. But I don't know. There's like some concerns around that too. I don't know since you work with kids if you have any opinion on that, and it's okay if you don't because it's not something I've branched out into yet either. But
yeah, I have used it in kids some, not for
okay.
obesity. I've used it for inflammatory conditions. Like
Ah, that makes
we all know
sense.
I treat pandas, PANS, that
Right, right, right.
pediatric condition. And I've used it for that. I have not used it for weight loss. Um,
Yeah.
so
Yeah. I feel like with
that's
kids, there's more opportunities to kind of clean up some of those epigenetic influences and
for
sort of
sure.
get the metabolism unstuck. I
Yeah.
think just as a general rule, kids have a little more malleability there, versus some of us
Yeah.
adults get a little stuck in our ways. But it's usually years of of things intermixed with the genetics kind of
Yeah,
expressing, and a lot of the genetic predispositions to metabolic disorder become more challenging the older folks get too. So there's a little more resilience in the early stages of life. So yeah, usually we won't have to do stuff like that.
yeah.
I know some
Can
other
I?
concerns. Oh, go ahead.
No, go
Yeah.
ahead. I was just going to talk about like the business model of it as well, but we can go into that later. Like, go
Oh
ahead.
yeah, yeah, we'll get to that
Question.
for sure. I was gonna say some of the other concerns that are out there, which, I guess we don't like. One of them was I think like thyroid cancer risk, which I think was kind of interesting. And I mean, most of my patients with any thyroid disorders, I'm monitoring them on a regular basis, and
For sure.
most people with thyroiditis, I've had ultrasounds done, at a regular interval and that kind of thing. So I haven't, I guess if there are risks of that nature, they probably will unfortunately become more apparent over time because they're not quick responses. So we don't always know that whenever they sort of force, phase 1, 2, 3 trials pretty quickly for a certain
Right.
condition, they get out there in the population. We don't know what the long-term effects are sometimes in these things, but you have to understand it's a balance. Even I said cancer is a metabolic disorder. So like, you may see improvements in overall metabolic health and inflammation, and that may actually be a bigger preventative factor for the development of some of these rare,
Exactly.
conditions. And then pancreatitis is another one that gets thrown around. I didn't want to like completely ignore altogether. I haven't seen pancreatitis, but I usually just warn people. I don't know if you have any ways of sort of looking at that too, in terms of prevention or certain body types or people that might be at higher risk.
Yeah. So, anybody with high triglycerides to begin with, right? I'm kind of a little bit more concerned about pancreatitis. Fast weight loss is like
That's a thing.
a downer. That's a downer. So this kind of is that segue into, you didn't even know it, Jamie, but it's kind of that segue into that business model. There are a
Ah,
lot of
yes.
doctors out there that want you, like they want you to pay per month to see them to be on these medications to do that. I don't work that way. I don't think that that's a healthful way of, because what it does is it forces patients to want to lose weight quickly because they don't want to pay you 250 every month or 550 or whatever your charge is, right?
Right.
So they are quick to not want to be part of that membership model. And
Right.
and I don't begrudge practitioners for having whatever business model you want, whatever works for you, right? I'm just saying for my personal practice, my patient population, I don't want them losing weight quickly. And
Right.
I would rather them be on the medication for 9 to 12 months and lose that weight slowly over time than I would 4 to 6 months fast and furious, right?
Right.
The
Yeah, a lot
gallbladder
of
is
issues
not
come up.
happy.
Yeah,
Yes.
exactly. With rapid weight loss. And also, a lot of our patients do have a lot of toxicities, and a lot of toxins are stored in the adipose tissue too. So,
Thank you. Yes. I see
yeah,
this
we
all the
don't talk
time.
about that very much.
Yeah.
But I mean, I know people who do pre-tox before they give semaglutides, and then do detoxification during. And then, some people, even if they're concluding later, and interestingly, there's probably a connection there too, because a lot of these toxins in the environment, which we'll talk about later, are endocrine disruptors, and they're challenging our metabolic system to begin with, and so it's kind of interesting to consider that function. And so yeah, anything rapid, I appreciate you saying that. That's kind of my take on it too, is I don't try to rapidly progress it. And yeah, the business model is an issue sometimes because there's a lot of these there are a lot of these internet businesses that are revolving door, and they're just zooming you and then giving you pretty progressive doses, especially if you don't have a lot of choice in titration. If you're dealing with the commercial products, sometimes and it's not always the best for the
Yeah.
patient. There's not a lot of monitoring and oversight. There's maybe a shorter interaction. It's always the classic things that we've talked about before in terms of treating the individual in front of you appropriately, and not
Right.
not practicing a revolving door medicine as far as
Yeah.
that goes. And so the risks may still be there, but the patient's aware of them. You have a good communication. You have a good rapport. You're going slow to their body type and what the risk factors may be. You're maybe running labs on them. I mean, there's so
For
many ways
sure.
to kind of operate around that.
To
Yeah.
speak to your concern about the pancreatitis, I do run in some patients that are more at risk. I do run like amylase, lipase, right? Some of these pancreatic.
Yeah.
So, I'll run those and see where we're at. Even in some cases where patients are a little bit higher, in those enzymes, I've seen them normalize.
Yeah.
Often lipase is low, often amylase is high. Anyway, I see those normalize over time. I've given semaglutide to patients with non-alcoholic fatty liver, right?
Yeah.
And so, and their liver enzymes are a little raised. It has normalized the liver enzymes. It's been wild, you know. I'm not, because this is a condition that most people would say is irreversible. And I'm not saying that we're reversing disease. I'm saying that we're at least reducing the inflammation that's present at the time to where maybe the disease doesn't have to advance at the rate that
Yeah,
it.
and the liver can recover pretty well if you can remove um, the toxic or
Right.
inflammatory or metabolic influences that are clogging it up or causing the problem. So even all, I mean, all the way up to like true cirrhosis where there's scarring, but like all the stages of liver disease prior to, you know, when it actually becomes more of a cirrhosis failure, sort of
Yes.
giant scar in the liver, basically, are often reversible or often able to be improved upon pretty significantly. So
Yeah.
it's
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 kind of
impressive
amazing.
to see that. Yeah,
Yeah.
absolutely. Yeah, and I guess I would probably say, you know, advise people to not to, you know, drink heavily when you're doing these things. I mean, like alcohol can be a contributor to some of these issues with pancreatitis or metabolism, metabolic
Sure.
shifting, and other things like that. I mean, that goes with the whole toxin thing though too, where
Right.
I'm like trying to clean people's toxins up in their life in general. So,
For sure.
you know,
The good news is that you don't crave the alcohol like you
that's
did
it. Yeah.
previously.
Yeah.
It's
Most people, I haven't run into that problem yet, but unless people are like closet, you know, drinking and not telling me, but there's always that possibility. But I haven't run into that problem as much with folks. In fact, I actually think you're right. I've seen it kind of help more.
sure.
And I think it's another motivating influence, and you know, to wonder why, you know, why people are drinking so much, and you know what they're sort of self-medicating, or what is providing to them.
Right.
It's one thing if it's like an occasional social situation. It's another thing if it's like sort of self-medicating some of the issues and maybe even some self-esteem stuff. Like, there's all these different
Yeah.
layers to it with the psychology of it too. It's really interesting. So,
But the good
um,
news is now they have mocktails. So you can go, you can
I know.
pretend to have your
Just
drink, you can do
talking
your
about
social
mocktails.
thing, and you can have a mocktail.
Mocktails make me laugh because they're like still like marking them up to the same level that
You
they would
still
with
pay
alcohol.
12 to
I know.
$15 for a
It's like
mocktail. And I'm like,
talk about a business model.
I know. Can I just have fizzy water, please?
I
With
know.
a
I'm just gonna drink water. I was like, at that point, I'm just
mint.
either gonna drink an herbal tea, or if somebody made like a herbal infused mocktail, I might be down for it. So, like, I want some kind of like cool medicinal benefit out of it, or something, or
Right. I
some
agree,
herbal
but
chill. You know.
I know exactly. But I am shocked at the prices of mocktails.
Well, if you're opening a restaurant, mocktails are apparently really good profit
Trend.
margin. So please, you know, go do whatever you got to do, but just make it interesting.
Right. Make it taste good.
Yeah.
If anything, make it taste good. But yeah, I would say overall, and there's a few podcasts that I would encourage our listeners, and maybe we can post these like in the, can you post these? Like,
Yeah, I think so. Yeah, I can post
yeah.
links, I
Okay.
think. That's the thing.
So yeah, thank you. The links to these podcasts. Dr. Tina Moore,
Mhm.
she's a fellow ND here in Oregon, and she has a series of 4 podcasts on semaglutide, Ozempic done right. I think I'm sorry, I don't know the name of her podcast, but it's a series of 4, and I have essentially given those to my patients to listen to because what I appreciate, and she says it with unapologetically, is eat more protein, lift weights, do all the lifestyle stuff and use these GLP-1 agonists as a tool to help you be where you need to be metabolically. And then go off of
Mhm.
them. And then use
Yeah.
them as a tune-up and then go off of them. And it just is a really healthy attitude for the way to approach this. Get your hormones right,
Yeah.
right?
Because that's another criticism. People are like, how long should I be doing these? And a lot of the media is all like, well, technically forever. And of course, you know, the classic story with pharma is that forever is like the best drug. Like if you can
Right,
keep people on a statin, a blood pressure med, and now you know, a semaglutide or something like that for a long period of time. I mean, that's lovely as a business model for them. Like, but
right.
that's not really the entire truth of it, is it? You know,
No,
that's
it's not.
not necessarily
And I think
how
it's
it is.
I think it's great to desensitize those receptors again, right? Let
Yeah.
those GLP-1 receptors in your body be, you know, like be free, right? And then these drugs will work again, right? And you can titrate up the dosage again. You don't have to keep the higher doses for longer because you will build a tolerance to them, right?
Yeah.
Over
This
so
is just a general question. There are a lot of supplements and other things out there now that are using the GLP name, and they're like, it's a GLP-1 support and all that kind of thing. Is that all bunk too, or does any of those things actually help clinically? I don't know.
I mean, I think you and I both know that yes, can they help clinically? Berberine, can it help, with blood sugar? Yes, it
Yeah,
sure can. I've seen a lot of advertisements like that these natural substances are like, nature's GLP and that they can help just as much. I have not found that to clinically be the case. As
yeah,
much as I want it to be the case. I so want it to be the case because I want to have an answer that isn't pharma and I
right.
want to have an answer that isn't dependence on the medication that patients have access to. I just haven't seen it. Have you?
Yeah, I mean, not necessarily. I think I've had people claim that maybe some of them do help a little bit, like maybe some of those probiotics. Like there's one with like Akkermansia and a few things that claim to do
Yes.
some GLP-1 stuff. It's like there could be many reasons. The microbiome research is not conclusive yet, too, in terms of like there are, I guess, obesogenic microbiome, or obviously the
Yeah.
metabolism in the body starts with like how your microbiome responds to the food you eat, what food you eat, and then how the microbiome responds to the food you eat. And so
Right.
there is a lot, there are a lot of complicated factors that are sort of in play there. So there was that animal study that wasn't repeated or really proven in humans where they transplanted a microbiome from an obese rat to a not obese rat or mouse even, I can't remember, and then vice versa, and they were able to make the non-obese rat obese and then the obese rat not obese. But
Yeah.
I've asked
Fascinating.
researchers on that who are actively researching the human microbiome. They're like, yeah, we don't really know if that's true or not in humans though yet. We haven't really done like any human studies on that. So a lot of the fecal microbiota transplantation research in humans is starting to look at different conditions and how the microbiome influences them and sort of trying to map
Yes.
out and parcel which areas. So I think at some point you're going to see more metabolically oriented microbiome supports. I mean, they even
Can we-
have FDA approved FMT now. It's just only for C. diff. So maybe someday it'll be
Yes.
for weight loss. Who knows?
So I'm just curious, like, can we do like a whole podcast on that? Because that is really like
Yes.
right now, my brain is all like gut microbiome, and like
Yeah.
as
And
most of us do know.
there's a lot we still don't know with microbiome. I'm trying to keep up with it as much as possible. And I'm sure there's some folks out there that have other stories. And a lot of it is like we have inclinations or, we have some ideas of what's what, but an individual's complex system and the interplays between all their microbiome as it comes together, their diversity and a little bit of this and a little bit of that. You want a lot of a little rather than a little of a lot, like a few guys running the show. You don't want that. You want a lot of different guys doing their little things
Diverse.
in harmony. So
Yes.
to really think about it as a big structure, I mean that is a whole podcast we could talk about, and I think there's still a lot that we need to learn, of course. Um,
So I have some patients on that note, I have some patients that can't lose weight on semaglutide. Like they don't
yeah,
have robust responses. And either they don't like, I've tried to really look into this. Like what is their stuck point, right? Do they not have the GLP receptors? Do they not have the volume? Are their receptors just different to where they're not responding to these medications? And it's actually leaning towards like uh there's a subset of those patients that when you give them more protein, like they lose weight, which is interesting. Then there's another subset of patients that if you optimize their gut health, they start losing weight. And that's a really interesting because a lot of these GLP-1s work in by modulating those gut bacteria, right? Or that interplay, right? They have to have players in the game. And so if you're a non-responder, it's worth investigating like what part of this might you be
yeah.
able to control
Absolutely.
or
Yeah, I
help?
mean, I think the whole gut liver interface, probably gallbladder, you can bile systems you can throw up in there too. But that whole interface there, there can be some weird things that aren't functioning properly that can really impede that process. I used to see that with keto with people too, and they were trying to do keto adaptation and there was some reason why there was something happening in that interface. A lot of times in that case it was the liver because the liver has to produce the ketones,
Right.
So if it's not
Right.
producing the ketones, there's a problem in the liver probably.
Yeah.
So people would just feel like crap, but they wouldn't actually lose any weight at all. And sometimes they would even gain weight. It was crazy.
Yeah.
So yeah, so there's a lot of one more big side effect I think that a lot of people are concerned about is like really bad depression or sort of mental health changes. And I know most of the time we talk about the positive influences on the psychology and this kind of thing, but had I've heard some reports about that, and I haven't. I haven't confirmed it to be the case, although I have had one patient who's sensitive to pretty much everything that had claimed that did happen to her. Have you seen that, and do you have any comment on it?
I have seen that, and I have seen it more as a response to titrating up. And so when
Ah,
patients actually get to an effective dose and they're kind of tolerating it, I've seen that depression lift from those patients. I've seen lack of motivation for myself. I get really fatigued when I
mm.
was titrating up the dose, and
Oh
so
yeah.
that was something to really like consider like that fatigue, but then it went away once I kind of got acclimated and got it at a dosage that worked for me and stayed there.
Hmm.
And again, we use lowest effective dose. There is no like goal target,
Hmm.
of where I try to get patients. It's like, what is your lowest effective dose? And that is where I sit. Um, and so you can mitigate some of that depressed feeling by, trying to again modulate the gut microbiome. And that's what I think it is. I think it's somehow, communicating with the gut and creating some of these feelings of fatigue and apathy and, lack of motivation. And I haven't seen it cause like frank depression in what I would term like a that sadness, despair type
Yeah.
of suicidality, like down that road.
Hmm.
It's been more like the fatigue, the apathy, you know. Can you clarify what your patient experienced?
Well, I mean, I think that in my theory, this patient specifically, anytime anything goes into her central nervous or has any activity in her central nervous system, there's a potential for some sort of flare in her nervous system. And so it's almost like any neuroactive drug could do that, or any neuroactive substance even on that front. And there are direct actions of GLPs in the nervous system and in the peripheral nerves too, is my understanding. And I was thinking maybe that was part of it, but her gut and her microbiome stuff are also incredibly complicated and probably at play. But this is I have a spectrum of patients that are sensitive, and this is a patient that is probably one of the most sensitive in terms of the ability to get movement on things, but is suffering from a metabolic disorder as a result of her chronic condition. So
And we know that there is a definite interaction between what is happening in the gut and what's happening in the brain. Like that
yeah,
is, we've known that for so long. And I think we're just starting to really appreciate, like, I still feel like we know this much.
yeah.
Maybe it's just me that just knows that much. Who out there knows more than that? You know,
I had one
who's told
patient
me that best?
who had a history with Lyme and neurologic manifestations in Lyme disease, and had claimed, I think, that it had actually helped a lot of her residual nervous system symptoms. And I think in her case, some of it was migraine. I think some of it was dizziness, vertigo type things, and some of it was just like brain foggy type stuff. So I've heard people tell me that what they call like symptoms of chronic neuroinflammation do tend to come down even in some of these sequelae situations, whatever you want to call it, if you want to call it post-treatment Lyme disease syndrome or whatever, title is out there.
Okay.
But sometimes it's kind of a cool thing to use sort of in the latter stages of treatment for the nervous system is what I've seen too.
Yes,
uh, and just lower doses usually in those cases, and it's kind of just a fun little consideration. And same thing with the mast cells. I mean, I think that a lot of people are excited about the prospect of it helping mast cell disorders, which
sure.
mast cell activation is sort of still a controversial diagnosis in the greater medical community, and even in the field of chronic illness, some people are like, yeah, mast cells, it's an entity, it's its thing. And then other people are like, no, it's secondary, and it probably is, but secondary to an active process we need to figure out. Is it mold? Is it babesia? Or is it a parasite? Or is it something that's really exciting those systems? And that's really the problem. So you're just blaming the mast cells completely is not it. But
Right.
you can always use mast cell modulating agents in a lot of these cases, and some of them work better than others. And so you kind of have these GLPs and sort of there as a tool in that spectrum for some of these people, especially when they have neurologic manifestations, is the way I would see it.
For
Or the metabolic disorder, clearly, which is common in mast cell too, having
It is.
metabolic syndrome.
And
So,
another thing that it helps with, and one of its claim to fame, like if I get a patient that's really edematous, they just carry a lot of edema, like
oh
their
yeah.
fingers swell, their legs swell, their body swells, independent of congestive heart failure and kidney,
Hmm.
disease, right? Renal disease. Like, although I bet that it would help those patients too, but I'm not here to speak on that, right?
Yeah,
But like
right.
just that. We know that a lot of patients in mold will start getting really puffy. Like
Yeah.
I'm sure you've seen that, right? Like they just carry a lot of water weight and puffiness. And my patients tell me that the semaglutide and tirzepatide both really help with that. So
Yeah.
that's probably the
Wow.
number one thing is like they notice right away, like I'm just less puffy, and which is
Yeah, you
amazing.
can see it with people pretty quickly too, that like some of the weight that comes off quicker with people is fluid weight, and which is like
Yes.
any weight loss program that you're doing, a lot of that time that's the case. You're not necessarily always losing the fat first. It's oftentimes fluid first versus fat
Right.
first.
Without
So
dehydration, right? Like it's not
yeah, exactly.
dehydrating them. It's just
Yeah.
helping get rid of
Excess.
excess fluid. Yes,
Yeah,
excess fluid.
exactly. What they call
And
the skin edema.
yes, and and maybe I don't know, and like time wise, if we want to make this the one of the last points that we talk about, or we can talk as long as you want, Jamie. But
Yeah, and we were supposed to be shorter today, so
I know we
we'll
were
go ahead.
supposed to be shorter, and here we are, right at an hour. But the a lot of people criticize these drugs because you tend to lose too much lean muscle mass,
Right.
and I would say that that is a key thing that and why I'd like to go low and slow, right? If you are if your hormones are adequate, you're getting enough protein, and you're exercising and doing strength training, and Dr. Tina's podcast, I mean, she nails it in. Like she doesn't mince words. If you're doing all of those things, you're not going to lose the lean muscle mass that you would otherwise, right?
Yeah.
And again, I have to emphasize the really slow weight loss because you're not going to lose as much lean muscle if you lose slowly, right?
Yeah.
And there have been some criticisms that like 30% of lean muscle loss on semaglutide and Ozempic. If you lose weight naturally, you also lose lean muscle mass. So
Yeah.
I just want to put that out there that whether you lose weight the old-fashioned way, with your sweat equity, literally,
Yeah.
or you lose weight using one of these medications, you're still at risk, right?
Yeah.
Either way.
And, no, that's a good point, and I mean, that is a concern and criticism too. To be fair, is that people are like, "Oh, yeah, you lost weight, but you also lost all your muscle," and that kind of thing at the same time. And this is the same thing with like keto diets too, which is why people I usually call it like modified keto. Like if you do nothing but just eat like 90% fat and you don't get protein in that, or you're not able to do some weight training or anything like that, then yeah, you're gonna inevitably lose it. And if your body goes into that type of state of metabolism, it's going to usually burn fat, but it's going to also burn protein. So you want it to burn fat over protein. You always want it to do that. So you do have to consider mitigation. And then maybe there's other hormonal influences too. Maybe people do need a little bit of anabolic support, like if they have low testosterone, or it could be men or women, sometimes need that a little bit too. So there's a lot of ways you can mitigate it, but it is an important concern regardless. I think if you just put people on medication and you don't do anything else and you kind of just let them roll and then they're not eating very much
Right.
and they're going to lose it all. And so they're going to technically lose weight and muscle is pretty heavy. So you even notice if you do hit the gym up and you're gaining some muscle mass, you're going to also gain some weight sometimes. And you'll be like, I just gained weight, but you're also like a little more buff. And that muscle is pretty thick and pretty dense and pretty heavy. So there's kind of a push and pull that has to be considered there for sure.
For
So
sure.
yeah,
And you
good.
can still yo-yo diet on using the semaglutides or
Oh
not
yeah.
using, right? That, like you lose weight and you gain more back because you've lost the muscle and now you gain, right?
Right.
That's totally possible. We're not
Right.
talking about a quick fix. We're talking about like a boost to help your lifestyle change,
Absolutely. Yeah,
And sometimes it's just that little motivation that you need to be like, okay, now I can take it from here, you know?
exactly.
So
No, this is good. Okay, well, I think that's a really good place to maybe wrap up for today because I said we'd be a little more concise, but we got to most of the things I think that I wanted to get to, if not all of them, and probably more than I even prepared. So, as usual, we don't really do a lot of intensive preparation for these talks. We kind of just go with it and see what happens. So, as we go along, maybe we'll tighten it up. But I like the sort of free form of it, and that's really what our goal was. So,
I did prep. I
any
prepped a whole 15 minutes before
oh,
we,
very good.
yes,
That's
I did it.
good. Yeah,
I did
15
it.
minutes. I think I probably read read some stuff this morning to keep it fresh in my mind, but it wasn't probably more than 15 minutes.
Good.
Because we do this stuff every day, and as part of it, I wanted it to be a little more organic. Like if we were asked this stuff by a patient or somebody kind of spontaneously, that we could come up with that answer confidently.
Yeah.
Because you can always over prepare things and make it sound like you know everything, but like it's nice to be able to kind of really think about it in the moment critically and kind of see if it all makes sense. So,
Yes.
and if it doesn't, then we have to go back and be like, oh, maybe I need to think about that differently. But
Yes, we do reserve the right to change our minds as
yes,
information comes out and new science comes out. And I tell my patients all the time, in 10 to 20 years, we're going to have really good data on this, whether this was a big scam or a really great, you
yeah,
know.
it's true. Yeah, so opinions may change as data, and that's what we try to do too, is continue to learn and keep up with all this stuff. And I think that that's very important. And share the anecdotes out there in the world, talk to people. It's important to understand things even before some published paper tells you what to feel or not, because that stuff is all important too. But uh, there's nothing wrong with observations and anecdotes and patterns and learning in real time with newer therapies and just really being mindful of that. So I really appreciate the pioneers in the world that kind of really take that seriously and not, like I said, don't just see a business opportunity, but rather an opportunity to really improve health and outcomes in a patient population that's really difficult to work with sometimes in terms of complexity and treatment, whatever you want to call it, treatment tolerance, treatment resistance. You can say all these different things. So anyway, we'll leave it there for today. Who knows what we'll talk about next week, but it'll be something interesting. You have a good rest of your day, and thank you
You
everybody for
too.
joining us. Any last thoughts there, Janelle?
No, thanks. I just hope you have a nice spring break, what's left of it.
Oh yes, thank you. You as well. And enjoy the time with the kids. Hopefully they're hanging out at spring break with you.
Yep. Today's my anniversary. Been
Oh,
married
happy anniversary.
23 years. Thank you.
23
Been
years. Oh my
23
gosh.
years. And
Wow.
and then I have my 18-year-old turns 19 on Sunday, so that's exciting. And so we kind
Wow.
of have some fam and my oldest child is coming home for a very short spring
Very
break
short.
stint. But
Yeah.
anyway, so it's going to be a fun weekend. I'm looking forward to it.
Awesome. Oh, that's
Yeah.
great. Well, thank you for joining me on your anniversary. Should be,
Thanks for joining me.
it looks like you're somewhere out on a ranch there, so that's good.
Yeah, this is I was going to say the neighborhood pond. So it's not my pond.
Okay.
It's
It's
kind
like
of
the
in my
water hole.
backyard. It's
Okay.
it's in the watering hole, yes. You can go fishing in this pond. You can catch some pretty big fish. It's catch and release though. They don't let you keep.
Okay. Still
Yeah.
fun. Right on.
So fun.
Love it.
Yeah. Beautiful.
All right. Well, thank you everyone for joining us. This is Confronting the Complex, as we call ourselves. Everybody have a good day. Take care.
Yeah. Take
Bye-bye.
care, Jane.
Thank you for listening to our podcast, Confronting the Complex, with Dr. Janell Payne and Dr. Jamie Kunkle. As a reminder, the views, thoughts, and opinions expressed by Dr. Jamie Kunkle are solely his own and do not reflect the views, policies, or positions of Gordon Medical Associates or its affiliates. Any content, discussions, or advice shared on this podcast are independent of Gordon Medical Associates and should not be interpreted as a representation of Gordon Medical Associates. Gordon Medical Associates does not endorse or take responsibility for any statements or viewpoints expressed in this podcast. Thank you, and I'll see you next time.